being just above I'm not an idiot to get in. So, you know, I guess that may be debatable for some, I don't know. You have to at least have had enough smarts about you and to get to the applicant pool and the interview side to have, you know, enough swagger to say, I can learn it and I can do it. Because the worst thing you can do is go out into the practice of medicine and be timid. I'm not telling you you're supposed to be a know-it-all, but you think about it, you get 2.5 years, and you got to be able to trust yourself and convince your patients that they're supposed to trust you, that you know what the heck you're doing. Okay? So be confident. I mean, go see Garth Brooks, I am. I would be going to see Taylor Swift too if she was in town. I've only seen her 4 times, but she's pretty awesome too. Now, speaking of stars, Selena Gomez. Do we know what chronic condition she suffers from?
Lupus.
It's lupus. Mm-hmm. Yeah, so she has a chronic inflammatory condition that pretty well treated, pretty well under control at this point. So what does that tell you about patients who suffer from chronic conditions that can have chronic pain associated with them? They can still be highly functioning. They can still be productive members of society. And even with medications that are employed safely, you can still be a rock in many sense of the word, right? Okay. I really don't care anything about music. I don't know why, but it's just the 3 examples we got today. What I care about is volleyball. Anybody in here play volleyball? Awesome. Did you play club volleyball?
No, I play basketball too, so.
Okay. Nobody else? Oh my goodness. Volleyball is the most wonderful sport ever. Both my kids play indoor club volleyball. My younger daughter, we just got back from U.S. Junior Nationals. Her team qualified for Nationals. What I will tell you is volleyball is awesome to watch. It's one of the fastest growing sports in the United States. Actually, women's basketball is taking a tank. Why? Because they're all going to play volleyball. If you have the chance, I want you to watch a little volleyball. One thing that you don't know is the United States Olympic training home for the U.S. women's and men's Paralympic sitting volleyball team is where? UCO. Do you go to UCO? There you go. It is amazing to watch. Who won the gold medal in the Olympics in Paralympic volleyball last year? The U.S. Okay? We beat China, who's our arch nemesis, because China cheats. We'll get into this in a second. All right, this deals with chronic pain. So China has a lady who is on their sitting team, who for years has played on their Olympic standing team. She's now on their sitting team. Because just because you're on the sitting team does not mean that you can't have all of your limbs. Paralympic rules allow for one minimal to be on the floor at any time. This is a minimal disability. Okay? Can anybody guess what this lady, she's 6'7"? And think about the Paralympic sitting volleyball net. It's like the height of this table. So this lady is like this, sitting on her butt. Okay? Guess what her minimal disability is? And it fits within IOC rules.
Arthritis.
She tore her medial meniscus in the Olympics standing last go round. So now she's on the sitting team. Because as long as she doesn't have her meniscus repaired, and they can prove that it's not been repaired with MRI given to the IOC, she has a minimal and she can be on the floor. And so that's pissed us off forever. And we finally beat China last year and we killed them. And so the U.S. Paralympic teams that are here in Oklahoma, actually they train here, won the gold. So if you ever get bored, they often have exhibitions, and UCO is the training ground. China actually came here last year and did an expedition. Canada was recently here as well. It's amazing, but if you get the chance, you gotta go watch women's volleyball. Men's volleyball is awesome, but all they do is just hit it like 4,000 miles an hour, and it's no fun because everybody just gets out of the way. Women's volleyball is really cool, and so both my kids play volleyball, and so that's far better than Garth Brooks and other stuff, but I'm going anyway. So we talked about acute pain, and now we look at in transition to chronic. So we talked about, the reason I talked about sort of the whole fibromyalgia thing is that's sort of the quintessential discussion on how we get central sensitization moving towards a chronic process. Okay, and we'll define acute chronic in just a second. But probably the most important thing on this slide, and I guess I can use a little stick just so I can say I used it this one time. This thing right here, NMDA. Have you all talked about NMDA receptors at all? Or you may not touch on them. So one of the medicines that's commonly used for the treatment of opiate addiction is what? There's a little clinic that they go up and they get their liquid once a day. Methadone. So methadone is not a pure opiate medication. Methadone actually has very limited opiate activity. Methadone is an NMDA drug. So although methadone was originally utilized as a medication to reduce opiate craving, we have found that methadone can have very potent pain relieving properties. And it works through this particular part right here, glutamate activated NMDA receptors. Okay, well here's the tough part with methadone. Methadone is cheap, very cheap. So in today's day, time of cost-based medicine, the Unaffordable Health Care Act, has pushed us into more and more cost-based medicine. There are a number of insurance plans that have mandated step therapy for opiate treatment in patients with pain. Methadone has shown up now as a you must fail before you go on certain other time-released or long-acting pain medicines. The problem is in the northeastern part of the United States, they're seeing overdose deaths on methadone prescribed for chronic pain like crazy. The reason being is methadone, each dose of methadone has a pain-relieving half-life of about 6 to 8 hours. But guess how long each dose of methadone stays in your body? Somebody take a wild guess.
24 hours?
48.
A month?
72.
3 days. 3 days. So how did Anna Nicole Smith die?
You know, I've been wondering about that.
Really? Methadone. So Anna Nicole Smith got methadone. And a lot of people who have been on opiates before think that if I take my pain medication, I should get some relief within 30 minutes to an hour. So if I take a short-acting hydrocodone or short-acting oxycodone or short-acting hydromorphone, whatever it may be, whatever I choose, I should be getting some sort of relief within 10 to 30 minutes. Methadone does not work that way, okay? You have to be very slow and methodical, and it takes a little while to build up a plasma level of methadone to where we get an appropriate pain-relieving plasma level. Well, how she died was she got methadone. She took methadone and said, well, this isn't working like my Percocet or whatever her treatment of choice was. So she took some more, and I'm still not getting relief, so she took some more. And she still didn't get any relief. Well, by the time that she started getting some pain relief, she built up a toxic level of methadone. She had respiratory suppression, her heart quit, and she just didn't wake up. So the NMDA receptor has been sort of one of these, wow, we really need to figure out a way by which we can target this receptor to try to help reduce the crossover from acute to chronic pain. But we've not really been able to do that yet, and methadone's really one of the only things that interacts with that receptor well. The problem is there are lots of side effects with that medicine. You've not been exposed to methadone, but another thing you need to know is methadone prolongs the QT interval. So you've had cardiology already, correct? Okay, somebody tell me what torsades is. So if I prolong my QT interval too long, so QT interval is basically the time in milliseconds that it takes for the heart to get ready to beat again, correct? If I prolong my QT interval too long, we can basically get the upper and the lower chambers beating at different intervals, and that's not good. So if you didn't already have the exam question, have you seen torsades on an EKG? It's a twisting complex. It's going to be on your exam sometime, where at the end of your clinical or didactic training or clinical training or on your exam, it's going to be there because there are multiple medicines that can prolong the QT interval. Methadone will prolong the QT interval. If we look at guidelines for prescribing methadone, you need to remember one thing about methadone. You should monitor EKG on at least an annual basis for somebody stable on methadone, and you need a QT interval that's less than 450 milliseconds. Beyond 450 is your flag for we need to make dose reduction or change them to something different. Now here's the difficult part. What other medicines have you been exposed to so far that prolong the QT interval? Say it louder.
Ketoconazole?
Okay. What else?
Phenergan?
You've not had psych yet. Have fun. Does Dr. Batassi teach the pharmacology? Cha-ching! Have you had her so far?
Yeah.
Oh, yeah. Okay. She's very good. That's all I'm going to say. Okay? She's very, very good. She knows her stuff. There are a plethora of psych drugs that can prolong the QT interval. Most of your atypical antipsychotics, your tricyclics, Celexa. So citalopram, very commonly used SSRI, now carries a box warning from the FDA. Anything above 60 milligrams, you are at risk for QT prolongation. So now I talked about I beat you to death with you've got to treat the mood component of your patients. Now you're saying, Jamie, what do I do with them if they need some sort of pharmacologic intervention? And you're telling me all these psych drugs prolong their QT interval and now their insurance is going to make me use methadone? Send them to pain specialists, don't do it yourself. That's what I'm going to tell you. It's too dangerous. But NMDA, very important from a modulatory standpoint with glutamate. You've talked about glutamate, aspartate, glycine, you know, all those things, right? So you know what, when I mention glutamate, what it actually is and what it's doing. Okay. Okay, so we've talked about all stuff. Is it necessary to classify what type of pain is it? I guess depending on how you want to choose your intervention, yes. Is it a nociceptive, is it a neuropathic, or is it an inflammatory response? Inflammatory would be things like rheumatoid arthritis or lupus or those types of things. If we think about, some sort of septic related issue. Okay, so other than the bad stuff that gonorrhea can do from a reproductive system, what else can it do? We can have a gonococcal septic arthritis. Don't think you won't see it. You'll see it. And so that's basically, an inflammatory response, and treat with antibiotics and anti-inflammatories, which is going to be different than somebody that you've identified with a neuropathic pain. So what would you think is probably the most common neuropathic pain syndrome we see? Diabetes. So you basically had some sort of either potentially demyelinating effect or some other neuropathy that's been produced peripherally because of some sort of condition. So it could be a diabetic process, it could be an ischemic process. So you have somebody that's had a DVT or somebody that's had some other ischemic process. Think about your smokers, okay? So they've got peripheral vascular disease, they're not getting good blood flow, they're not getting good oxygen flow. They're gonna start killing those nerves, and so they can develop a peripheral neuropathic set of symptoms. That's an ischemic neuropathy, not necessarily something that's, started from a diabetic process or something of that nature. So just in classifying those, we've mentioned the word nociceptive, these are things like somatic versus visceral or hollow organ pain. These are a response to a noxious stimuli or injury, tissue injury, those kinds of things. Neuropathic, these are caused by some sort of lesion or disease within the nervous system. And so this can be manifested by things such as numbness or tingling or even we love in the world of pain to use these terms called hyperalgesia and allodynia. Hyperalgesia is basically an exaggerated response to a painful stimuli, which is different than allodynia. And allodynia is causing a pain response with a non-noxious stimuli. And it's very common in patients who have a centralized sensitivity or a chronic global widespread pain syndrome that they'll be hyperalgesic and allodynic. But those are two very important things to really think about. Are they having an exaggerated response from a normally noxious stimuli, but it shouldn't cause that large of a response? Or are they having a response to a non-noxious stimulus, but are reporting it as uncomfortable or painful? Inflammatory, we talked about this very briefly just a moment ago, but these can really come from any inflammatory, infective, or septic process. So anything from anything that ends in itis, so any of your infections or inflammatory processes, your rheumatoid arthritis, your Crohn's disease, you've got basically, if you look at Crohn's or ulcerative colitis, you can have an inflammation in your entire gastrointestinal tract from your mouth all the way to the anus. And so these patients oftentimes end up in our clinics dealing with chronic pain. They have an inflammatory condition that they may be on something like Humira, which is anti-rheumatologic or disease-modifying drug to help reduce the organic nature of their disease, but then they're also having a fair bit of pain. The inflammatory side is where we can really get involved with a lot of different pro-inflammatory factors, and there's a lot of research looking at this side of the world. How do we modulate interleukins and tumor necrosis factors and chemokines and cytokines and so forth, and can we modulate those in treating pain in a completely different way? There's actually a drug right now that's being co-studied by two of the largest pharmaceutical companies in the world. Eli Lilly and Pfizer are in joint study of a drug right now, which is basically an antibody that is looking at dealing with these types of issues in treating pain by using antibodies. So it's been fast-tracked, believe it or not, by the FDA. So if you've got a little extra money laying around, you may want to invest in Lilly and Pfizer, and we'll see. I think Pfizer's stock is up 50% over the last 5 years, and they'll probably continue to grow because this drug looks very promising. And if they can continue to show limited potential side effects, it's going to be a blockbuster in what we do, because it doesn't carry the risks of abuse, misuse, diversion, and unintentional overdose death. So As we talked about before, there's no scan, there's no laboratory test, there's none of those things that can really quantify pain for you other than the patient's report. So in your history taking, you've got to document or quantify a patient's pain. We commonly use a visual analog scale. Usually it's a 0 to 10. I tell patients 0 is no pain, 10 is burned alive. Because so many patients want to come in and tell me I'm a 9 or a 10. And I said, well, you walk through the door and you're talking to me right now, and you're not having any issue sitting in the chair. I want you to reclassify your pain as 0 is nothing and 10 is burned alive. Where are you at in that? Because I don't think you're being burned alive right now. And so the tough part is that you're not treating a number, but you do need to classify, are they mild, moderate, or severe, and this is the standard rating scale. But every patient is different. You can have a patient that rates their pain as a 3, and they are kyphoscoliotic, they can't hardly walk, and they wince in pain with every step. Now, are they truly a 3 versus another patient that may have OA of the left knee and walks in and out of here just fine, but they say their pain is a 7 all the time? Every pain scale score that you get from every patient is a little bit different, but this is at least one standard way you're going to document in your notes that I've at least asked them how they're perceiving their pain, and we're going to use a standardized scale. Is it that you're attempting to compare one patient to the next? No. But you are using this scale to see how effective your intervention is. If I started with a pain level of 8, and I've provided some sort of intervention, one of the things that you have to document is how effective is my intervention? Because if it is not effective, either A, I need to reconsider intervention, reconsider my diagnosis, or consider discontinuation of therapy if we're getting no benefit from that, because there's always potential adverse effects from any therapy we employ. Time course, anything 3 to 6 months is considered acute, beyond 6 months is considered chronic. There is what's known as acute on chronic pain. There's really 2 different types. It's either disease progression or an acute flare of what's really kind of going on already with the particular patient. So as I mentioned earlier, the most important thing that you can do with patients is talk with them. Your history is 85% of making a diagnosis. And so when we look at assessment with these patients, one thing that you have to do, it all goes back to the psychological portion of this. It's basically reassuring patients that A, you're listening, B, you take them seriously, C, you believe them, and D, you're going to set realistic expectations, because the worst thing you can do is set an unrealistic expectation, because you're going to fail. And unfortunately, I see this in surgery all of the time. Neurosurgeon tells the patient that they've got a frankly extruded disc at L3-4, and they're going to go in and do a posterior decompression, and they're going to do a single level fusion, and you're going to be back to work in no time. 10 years later, they're still in my clinic with chronic intractable pain. The structure looks okay, but the physiology has changed, and they're still angry because they were told this was going to fix them. So patients commonly will come in with a narrow set of blinders on, and they are looking for a fix. And I tell every one of my patients, you got here because a lot of smart people couldn't fix you. I'm not the smartest person that you've ever seen, and I'm not going to fix you. And I've got no crystal ball that's going to tell me if you're ever going to be fixed. So instead of this being a one-night stand, this is a long-term relationship. Surgeons are one-night stands. We're going to get in, we're going to get out, and you're going to be fixed. With me, it's a long-term relationship because I can't guarantee you that you're going to be fixed. So what we have to do is we have to get beyond especially in our chronic patients, we have to get beyond the desire to be fixed and to be without, and to learn to live alongside. So very commonly, I recommend a book to patients. It's called Kitchen Table Wisdom. It's written by a physician named Rachel Remen, R-E-M-E-N. Anybody that you see that has potential chronic pain, they need to go buy this book. You can get it on Amazon paperback for about $3.50. It is the chicken soup for the soul version of chronic pain written by a physician who has got some great insight, and it's a wonderful book for any patient that's dealing with chronic pain. After that, if you've got a patient that's moving through, working through sort of the grieving process and they're wanting to be challenged a little more, there's another book called Body Broken. But it's an absolute reach out of the pages and slap you in the face over and over about dealing with chronic pain as a patient. But it's also written by a physician, and her name is escaping me right now, but it's called Body Broken. It's a very good book as well. And we recommend these to our patients all the time. But a lot of that goes through with reassuring patients that you're listening to them, but you're going to set appropriate expectations. Because if you set inappropriate expectations, you're going to fail every time, okay? History and exam, we talked about that briefly. You're going to hear that, and no matter whether you're working in cardiology, whether you're working in family medicine, whether you're working in pediatrics, whether you're in the ER or whatever, it's all about history exam, history exam, history exam, and document out the yin-yang. You need to do a thorough history, thorough exam. That includes psych exam, although a lot of you are going to want to shy away from that because psych isn't any fun. You got to do a thorough psych exam. You got to do a thorough neurological and musculoskeletal exam. You don't want to have somebody that comes in and complains of back pain and you just take their word for it and you don't really do a thorough workup on exam, and when you could have had them change into a pair, let's say it's December and they got long pants on and they complain of back pain and you take their word for it, and all this has been going on 6 months, and it was after I lifted a bag of Quikrete because I was doing a patio in my backyard. Oh yeah, that sounds like it would hurt. Okay, yeah, let's treat you with some anti-inflammatories. If you don't get any better, we may consider doing a scan or send you to physical therapy. And if you'd had him change into a pair of shorts or an exam gown, and you look at him and he's got significant atrophy of his calf muscle, what are you thinking? Dang, I just screwed up, because this guy potentially has an extruded disc that's laying up next to a nerve, or we've got a canal stenosis, a foraminal stenosis, and I've got nerve impingement, and I've got a lesion in the nervous system that's caused an atrophy in his musculoskeletal system, in his muscle, and I've screwed up because I didn't do a proper exam. Instead, I'm busy, I just want to throw some medicine at you, you'll get better. He told his last doctor, if you just give me 4 hydrocodone a day, I can keep going. Yeah, well, there's something a little worse going on in there, so you don't get lazy. All of us want to do it, we all get busy, but don't do it. Pain history, it's a lot of information to ask with patients, especially in the environment that we're in right now with the opiate abuse, misuse, and diversion side of the world. You've got to document very well. So that's really looking at, write the mnemonic down. You're going to need to know it. Put it in your little book. You're going to want to know temporal characteristics, aggravating, relieving factors, past responses, expectation, and physical exam. So quality, quantity, intensity, characteristics, aggravating, alleviating, impact on pain, quality of life, past treatment, and response. Ask it every single time. That's not only on initial assessment, but you're going to want to ask it at repeat assessment, because you want to know how much is your intervention actually helping. Did you set the right expectation? Is the patient meeting their goals in treatment, or do we need to employ either further diagnostic testing, some sort of other imaging, looking at some other referral, or changing or adding to what it is that we're doing in treatment? So this is all that we've talked about up to this point, is that it's a multimodal, multifactorial process in treating pain. You've got to treat not only removal of the stimulus, if there's one still present, you want to look at the entire cascade of employing some sort of intervention at transduction, transmission, perception, cognitive behavioral things, the psych side of things, as well as the descending pathway in modulating that as well. And those goals have to be explicitly outlined with your patient. One of the worst mistakes you can make is start treating somebody's acute pain with no goal in mind, either time course in therapy or reduction in pain to a certain functional level. If you don't have a goal in mind, unfortunately, patients at times are going to take advantage of you. Even at resolution of their symptoms, they sort of like the euphoria that they get from that oxycodone. And so if you didn't set a proper time course in and realistic expectation of patients that I'm willing to treat you for up to 90 days. Beyond that, it becomes a chronic issue, and you've got to move to another clinician, whether it be pain specialist or have some further evaluation with rheumatology, neurology, neurosurgery, and so forth. If you've not set that, you've either A, set yourself up to be taken advantage of, or B, you've set yourself up for the patient to become very angry at you. Because when you come in at that third visit and say, listen, you know, we've been doing this for 90 days and you keep wanting 6 hydrocodone a day, you know, we're just not getting anywhere. Yeah, we are, I'm better. Well, you know, really at 90 days, beyond that, you should be in a different place than we are. No, you didn't tell me that. You told me that we were going to treat my pain this way. So you set yourself up to fail if you've not set the proper expectations of the patient. And part of that is explicitly discussing with them, what is the diagnosis? What is the treatment options available? What are the pros and cons of those? What is the time course in your comfort level in treating them, and a future plan if necessary for referral to some other form of therapy. So in all of our, especially initial history of physicals, when patients leave, they get both written and verbal instructions. And in that list, it will include, I'm doing what I'm doing today, and these are the things that we're going to consider at time course A, B, or C if we've not gotten to where we need to be. And that may be, we're going to do physical therapy, and if we've gotten not where we need to be after this many sessions, then we're going to be evaluated by the orthopedics, or we're going to have an EMG done. And once we've had the EMG done, then based on those results, then I'll decide, do we need to have an MRI, or do we need to see neurosurgery, or whatever it needs to be. So in your treatment plan, it's not, let's just do this. Now, would you do that in treating a urinary tract infection? Would you say, Miss Jones, you've got a urinary tract infection, so I'm going to put you on Bactrim DS, one of them twice a day for, I don't even know what the guidelines are right now, maybe 3 days. Let's just say, I think 3 days is the right thing. Are you going to say, that's what we're going to do and I'll see you later? Or do you say, I'm going to follow up with you in 10 days, we're going to get a repeat urine. If we're still having appreciable pain, discomfort, bacteria present, we're going to look at the culture and sensitivity, either change drug, or I'm going to get you in with a urologist because this has been something that's been going on over and over, and they need to do a voiding study or a cystourethrogram, or, you know, what is it that's going on? You've got some sort of future plan, a follow-up plan. You've got to do the same thing with your pain folks, and you've got to set the expectation of time course so that you know what your next step is going to be. You've always got to stay one step ahead, because if not, you're going to get burned. So what are the major goals? Resolution of symptoms enough so that they can have an improved quality of life. With the lowest potential dose, the maximum potential reduction in symptoms with the fewest potential side effects. And the reason I say fewest potential side effects is because everything comes with baggage. Everything. And so you've got to consider, you've got to always weigh pros versus cons in any of the treatments that you employ. And you have to weigh, there are going to be some side effects, and is the patient willing, with use of pregabalin, that for a little while they may feel a little dizzy as we're titrating up on this, but then that settles out. Is that something you discussed with them? Is that something they're willing to work through, knowing that they're getting some benefit from the medication, but you set that up in the beginning with a lot of patient education, and it takes time. So our chronic pain goals are really no different, but with chronic pain it's all about safety. These are folks that have been in the system a long time. They've been on a lot of different medications. They've been through all types of different surgeries, interventions. They may have had spinal cord stimulation. They may have other injections from interventional pain management. They may have epidural steroid injections, rhizotomies, ablations, other types of procedures. Our goal with the chronic pain folks is we want to make sure at each visit the medicines that we're employing are improving function, they're able to complete activities of daily living, there's an appreciable response that is positive to those medications, but they are safe without any adverse effect that's impairing them in any way. patients that I write medicine to, or that we write medicine to in our clinic, I tell them that they should be able to take the medication and tell me that they don't know they've taken it, other than their pain level is less and their ability to function is an appropriate level to complete activities of daily living or continue to work if they're still working. But at no point in time should they ever have signs or symptoms of impairment. So patients commonly will say, "Can I drive while I'm on these medications?" Should a patient drive on opiate therapy? Sort of a conundrum, isn't it? What if I told you I've got patients that drive public school buses? What if I tell you that workover rig that's driving down the road from western Oklahoma to go set up shop somewhere else is driven by a patient of mine that's on pain medication? What if I tell you one of the local locomotives that goes through downtown, that chief engineer sitting behind one of those locomotives is on pain medicine? What if I tell you the cardiologist that is seeing you and putting in a stent in your grandmother is on pain medicine? What if I tell you the orthopedic surgeon that's operating on your knee is on pain medicine? So I get a lot of funny looks. But as long as they are taking the medicine appropriately and not impaired, why should it impact their ability to work? Aren't there side effects that can happen with blood pressure medicines? We can get orthostatic and get dizzy, and beta blockers can cause depression and clouded thinking. Psychiatric medicines can cause all kinds of things. Diabetics, we can get hypoglycemic on our insulin. We can get really weird. Why is it okay? Why is the stigma such that if your neurosurgeon had type 1 diabetes and was on an insulin pump, you would say that's acceptable? But I get a lot of raised eyebrows if I said your neurosurgeon has chronic back pain from leaning over that table for 35 years and he's taking hydrocodone 5 a couple of times a day after he gets off work. Why is it any different?
Because of the history of abuse,
But the patient doesn't have any history of abuse.
just overall.
So it's basically the public taboo. It's the public perception. So in medicine, we are all hypocrites, right? Is chronic pain a disease? Can I show in what I've talked about, can we show that someone can develop chronic pain through a physiological process such that it is a disease state, correct? You'd say, I can pretty well make that argument. It's a disease. Why is it acceptable then to treat chronic diseases such as diabetes, hypertension, hyperlipidemia, endocrine issues? Why is it okay to treat other chronic conditions and not think twice about it, but not treat chronic pain as a disease? What are we doing in hypertension? Why are we reducing lipid levels in hyperlipidemia? Why are we treating diabetes patients? We want to have them be able to have an improvement in quality of life and reduction in negative events down the road, correct? What are we doing in chronic pain patients? We're helping them to have some quality of life, right? So I challenge you to not be a hypocrite in medicine. So many of your colleagues are. And that the treatment of chronic pain and even acute pain done appropriately and managed correctly does not have to be a negative thing, and it doesn't have to be a taboo. Yes, there is abuse, misuse, and diversion. We've not even got to, and I don't even know that we're going to get to, deal with tolerance versus dependence, but we'll talk about that when I do the sleep lectures. We're going to do addiction at the same time. So part of that I'm not worried about getting to, because we're going to get to in those lectures. But oftentimes people will say, well, because somebody has developed tolerance, and if I remove the drug from them, They're gonna have side effects or withdrawal because of dependence. You've had cardiology, right? What happens if I got a patient on clonidine that's taking it 0.1 milligrams twice a day or on a clonidine patch because they oftentimes are in hypertensive urgency, and so the cardiologist decides to put them on clonidine? What happens if I abruptly withdraw clonidine? We're gonna have a rebound hypertension and potentially put them in hypertensive urgency or even hypertensive crisis. So is it not fair to say that other medicines that we use, we develop tolerance or dependence upon? What if I've got a diabetic and I take their glycemic control medicines away? Are their symptoms not going to return? Are they not dependent upon the use of those medications for a quality of life? What if I've got a hyperlipidemic patient that used to have a cholesterol over 400 and they've got plaques all over the place and they're just a vasculopath, and I've got their cholesterol now under 200 because they're on a statin drug, which I'm not a huge fan of, and I'll tell you in just a second. But if I take their medicine away and they have a return in high cholesterol levels, and then they have a stroke and I get blamed for that, were they not dependent upon the use of that medicine to lower their cholesterol such that it was potentially in a safe realm so that they didn't have a stroke or heart attack? So I challenge you to not be a hypocrite when you think about treating certain conditions in medicine and not treating others. Now, statin drugs. I know this isn't a cardiology lecture, but this is my pet peeve. Statin drugs are responsible for more patients developing what chronic heart condition than ever before. And I hope whoever lectured you on statin drugs told you this. Dr. Batassi? I hope she told you this.
So like a cardiomyopathy?
Why?
Because the heart, it weakens the muscles over time.
What do statin drugs deplete? This is going on this exam, whether it's cardiology or not. What do statin drugs deplete? You see it on TV all the time and you don't even think about it. Coenzyme Q10. Statin drugs deplete CoQ10, and CoQ10 is absolutely necessary for appropriate cardiac function. If you look at post-marketing data in the cardiology world with the use of statins, the incidence of heart failure has gone through the roof. Now, why is it that you don't see on the news local cardiologists arrested and charged for the death of 2,000 patients because of heart failure because of statin drugs? But you'll see yesterday, Sherman Denison doctor arrested and federally charged 5 counts of overdose death. 2 weeks ago, Midwest City doctor charged with 5 state counts of unintentional overdose death on opiates. There's a taboo even in our legislative and law enforcement environment. But if you're going to write a statin drug, you better replace coenzyme Q10. I'm just telling you. There's also, I'm going to encourage you, you're going to look up a cardiologist. Does anybody here think they want to go into cardiology or cardiovascular medicine? We got a couple of hands. Okay. So you folks need to look up a doctor in Dallas. His name is Dr. Frank Sinatra. You can't forget the name. I kid you not. His name is Dr. Frank Sinatra. He did some of the initial studies on statin drugs. He is now one of the most vocal physicians against the use of statins. Because if we look at post-marketing data, and if we look at literature, cholesterol is not the problem. Believe it or not, no matter what you've been told up to this point, cholesterol is not the problem. Inflammation is the problem. So cholesterol plaques start because of an inflammatory response in the intima lining. So if we have the ability to reduce the inflammation, we can reduce the potential cholesterol plaque formation. All statin drugs do is reduce cholesterol, which the good Lord gave us cholesterol for a reason. Everything that's in our bodies is there for a reason. We don't know long-term what significant reduction in cholesterol actually does to us as a human race. But what I can tell you is it's an inflammation process not just a cholesterol process. And Dr. Sinatra has some great information about the inflammatory response and why statin drugs aren't just the answer. But that's my off on another end. Coenzyme Q10, absolutely necessary if you're going to write statin drugs. We talked about all of those things. Acute on chronic pain, acute exacerbation. This is either disease progression in somebody who has a disease process such as, let's say, rheumatoid arthritis. They may be on disease-modifying anti-rheumatologic agents, but they've had joint destruction that has progressed because of that. And they may have a progression in their pain because of that disease progression, or they may just have an acute pain flare. Just because somebody's on pain medication doesn't mean they've got no pain in their body ever from then on. So they may have pain medication that is dosed to a baseline level of what their current pain issues are. But if I've got low back pain and I'm on medication for my low back pain, and my low back pain, you know, I average it at 2 or 3 and I'm able to function on a daily basis, but then I need to go in and have knee replacement, is it fair to assume that my baseline level, that my 3 hydrocodone a day that keeps my back pain under good control is all I need for postoperative pain after I have my knee replaced? No, because we basically have an acute on chronic flare because of that surgical intervention that is sending signals all the way through your whole pain process in a completely different area. So somatosensory cortex is dealing with this now, and it's still dealing with this, but it's dealing with this as well. Now, pain medicines aren't smart, okay? So they're kind of like me. They're not very smart. Pain medicines don't know when you ingest them that the left knee hurts, right? They don't know that the big toe hurts. They don't know that the back hurts. What they do is they go and if they're opiates, they're binding in several different presynaptic, postsynaptic areas, the thalamus and so forth. But they're not smart. Let's just use an anti-inflammatory for an example. I twisted my left knee, and that's not the left knee, the left knee, and it's inflamed, and so I'm going to use an anti-inflammatory. And I take an oral anti-inflammatory. Well, that drug does not know that I've given it for the left knee. What is it doing? How does an anti-inflammatory know? It doesn't really think, but how does it know where to go? What do non-steroidals bind to? Louder. Okay, so inflammatory synovial fluid in that twisted knee has a large amount of protein, correct? Inflammatory areas have a fair bit of protein floating around. The non-steroidals are actually going to look for that, to go bind in those areas. So if we look at the most widely marketed non-steroidal worldwide, diclofenac. So diclofenac sort of, if you've talked through COX-1 and COX-2, I don't know if you've gotten there yet. Diclofenac sort of sits pretty middle of the road on hitting on COX-1 and COX-2. It's pretty cheap. So diclofenac now comes in a patch form, a gel form, a liquid form, a liquid gel cap, 2 different types of compressed tablets. There's a study going on right now for diclofenac plus hyaluronic acid injection for the knees. Diclofenac's used in a gazillion different preparations. Diclofenac is one of the most highly protein-bound non-steroidals on the market. So when it's used, it's hunting through the body and looking for the ability to bind to protein, and that's where it knows to go. So that's why if somebody's knee hurts, they may come in and say, well, you know, you started me on that diclofenac, but I noticed that my neck is not as stiff as it was before. Well, that medicine didn't know to go look for the knee. That medicine was just going to look for areas that may be inflamed that have more protein available for it to bind to, and so that's where it's going to bind, and that's where we're going to get reduction in transmission of symptoms. Okay? Breakthrough pain. This is kind of a controversial thing in the world of pain management. A lot of chronic non-cancer pain doctors don't use this term. Breakthrough pain was really a term that was hallmarked by oncology for cancer pain patients who then would have periodic spikes in their pain, and this was called breakthrough pain. It was breaking through what their normal baseline, their normal baseline sort of pain levels might be with their medication. We in our clinic use the term breakthrough pain, and that's just a preference that we have with discussion with our patients, because a lot of them are on time-release medication, and they may have periodic flares because of certain activities or long car rides, or they did something they weren't supposed to, and now they have an acute on chronic flare, and we just, instead of documenting it as an acute on chronic flare, we choose to use the term breakthrough, but that's technically a term that was hallmarked by the oncology folks, but it just basically means a flare of pain on top of or beyond what you're currently dosing medication to at the time. We talked about those. Most important thing when choosing your treatment are the 5 R's. You better write this down, you better use it every time. You gotta be right, okay? I make the nurses in my clinic write down when a patient tells me I was right, because it's not very often that the nurses let me be right. Just remember, your nurses are your best friends and they know a lot of stuff. So be good friends with your nurses, and they're always right. But I like to be right sometimes, and that's these things right here. You gotta make sure you're using the right analgesic, the right dose, the right route of administration, the right interval, and the right expectations. And the 5th one is probably the most important. Set the correct expectations. But this way, this is the easy way to make sure that you and your patient are always on the right path with one another, okay? So make sure you're choosing the right medicine, the right dose, the right way by which it's being administered, and the right interval. Interventional folks, the interventional pain guys, there's a lot of them in town. There's a lot of very good ones in town. These guys employ a number of different types of therapies. So in addition to oral or transdermal medications, we can use interventional pain management approaches. These would be epidural steroid injections, lysis or ablations, rhizotomy, spinal cord stimulation, implantation of intrathecal devices. These kind of walk through some of the things that we've already talked about. Spinal cord stimulation I talked about, it's really being moved up in the treatment cascade. Radiofrequency ablation used to be thought of only in patients with limited life expectancy. That's actually completely changed. We use ablations and rhizotomies very frequently now. If somebody's had a response to a diagnostic nerve block in their back, and it only lasted for a short period of time, we can go in and have the interventional guys ablate that nerve, which is basically a temporary permanent stunning of that nerve for up to 6 months. Some people may even get to 12 months of reduction. That nerve will regenerate and start causing pain at some point again, but they can go in and repeat that. And basically they use a radio frequency to ablate those nerves. One of the neatest procedures that I can tell you about in chronic knee pain folks, especially those that have had knee replacement, still with pain, is a procedure called a geniculate nerve block and ablation. There's a couple of guys in town that use cooled radiofrequency ablation of the geniculate nerve. It's a very effective procedure for your post-operative and or post-knee replacement folks with a lot of pain, but there's a big body of research looking at doing preoperative geniculate ablations before surgery. So being the provider that I am, I signed my dad up for that. I had him do a preoperative geniculate ablation before he had knee replacement. And he called me the day after the procedure was done, and he said, "Is there anything I should not be doing after this procedure?" I said, "I don't know, I don't do the procedure." So I texted the interventional doctor that did it, because he and I've got a good relationship. And he said, no limitations for your dad. Tell him to do whatever he wants. And so I called my dad back. I said, He said, no limitations, but I still want to know why. And he said, oh, I decided to till the garden today. This is a man who the orthopedist said, I have no idea how you're walking, because he was the most bow-legged guy you'd ever seen, and he couldn't hardly walk. The only reason he was convinced to do knee replacement is my kids beat him up every day about, you know, how old he looks, gimping around, and he was in obvious pain. And the orthopedist just said, we should have replaced this thing 10-some years ago. This is awful. He had a geniculate nerve ablation and said, this is the best my knee's felt in 20 years. I don't want to have surgery. And I said, BS. You're going to have surgery. Well, with it though, 2 weeks post-op, he and I went fishing. 3 weeks post-op, we went turkey hunting, because we did this last spring. 3 weeks post-op, we went turkey hunting. 5 weeks post-op, he drove to Kansas City with me and sat in a volleyball gym watching my daughter play for 3 days without any issues whatsoever. He took pain medicine post-operatively for 2 days. Now, is he the norm? No. But there's a large body of evidence that shows that if we'll employ some of these interventional techniques early on, even before surgical procedures, our ability to heal post-operatively can be dramatically different. There's a large clinic in Chicago that there's an orthopedic physician, or an interventional physician that's working with a group of orthopedics, and they have now started doing, his whole clinic is only doing geniculate ablations and blocks pre-surgical intervention on the knee, most of them knee replacements, and they're compiling a huge amount of very positive data. So keep that in the back of your mind if any of you are these cowboys that want to go work in orthopedic surgery. I'll let you have it. I'm never going down that road. But if you guys go into that form of medicine, remember those kind of things. Time course we talked about, treatment end. Why would we stop treatment? We've met our goals. So that's always a good one. When you meet your goal, we can stop therapy. We also, though, need to stop therapy if treatment hasn't worked despite adequate adjustments or an adequate time course. We're going to stop therapy if patients just unwilling to do what we've asked them to do. Or we're going to stop if the goals aren't met or not achievable. There's no reason to consider some sort of continuing intervention from a medication standpoint. Or is there any reason to have a patient continue to have 15 epidural steroid injections if they told you the first one and the second one didn't ever help? You're going to see it. You're going to see patients that have chronic back pain that you're going to come into your clinic and you're going to ask them about what other things have you employed in the past for treatment. And they'll tell you, well, I'm getting ready to have epidural steroid injection number 27. Have they ever helped any? I don't think so. But the doctor said, I got to keep having them or he's not going to write my pain medicine anymore. I can't tell you how many times I've seen that. That patients feel like they're backed into a corner, that the only way they can continue to receive the therapy that really helps is to keep putting themselves in a situation where they have to accept a form of therapy that is potentially harmful or not beneficial. Okay? Specialist referral. So I've talked about a lot of this from my perspective being in the pain management world. I would probably venture to guess there's not a single person in this room that's going to end up in the pain specialty arena. But you are all going to be faced with dealing with acute and or chronic pain patients at some point. And you have to know what your limitations are, and you have to know when to refer them, and you have to know where to refer them. So you're either having to consider what your diagnosis is, what treatment options you've employed, what further workup you need to do to decide, is this a neurologic issue, neurologist, is this a neurosurgery issue, is this a rheumatologic issue, or is this a chronic issue requiring chronic ongoing opiate therapy, which I really don't need to be engaging in, and I need to send this on to specialty medicine. Regulatory issues. Whether you are in pain management or not, if you ever write a controlled drug, you need to be very, very, very aware of the regulatory environment we're in right now. You need to go look up and or read the CDC opioid treatment guidelines. You need to read the Oklahoma opioid treatment guidelines both for emergency medicine and outpatient therapy. You need to go read the Controlled Substances Act. you need to be very aware of what the Oklahoma State Bureau of Narcotics as well as your state medical board say about the use of controlled drugs in our state and in your patients. Because we as PAs have prescriptive rights to write Schedule 3, 4, and 5 drugs, correct?